Hello, and welcome to our fourth Friends Health Chat. I'm Chris Collins of Friends of the Global Fight Against AIDS, Tuberculosis, and Malaria. To find out about future webinars, please follow us on Twitter and sign up for our email newsletter on our website, www.theglobalfight.org. Today, I'm very pleased to be joined by Dr. Tom Frieden, President and CEO of Resolve to Save Lives, an initiative of Vital Strategies. As you know, Dr. Frieden formerly served as the Director of the Centers for Disease Control and Prevention and as Commissioner of the New York City Health Department. As Health Commissioner, he spearheaded numerous programs to improve public health, including a tobacco program that prevented more than 100,000 deaths from smoking. At CDC, he led successful efforts to contain the Ebola epidemic of 2014 to 2016. Since the advent of COVID-19, Dr. Frieden has been a leading authority and communicator on the science of the pandemic and the response that's needed. Today, we're going to focus on global health security and pandemic preparedness, specifically what the United States and its partners in the world should be doing to be better prepared to address the next pandemic. I'll ask Dr. Frieden several questions, and then we'll have about 10 minutes for questions from you. Please submit questions using the Q&A feature at any time, and we'll get to as many as we can. Dr. Frieden, welcome, and thanks very much for joining us.
It's great to discuss this with you, Chris, and I look forward to the conversation.
So first question, yesterday you released a brand new report, Epidemics That Didn't Happen, highlighting preparedness success stories from around the world. And for the audience, see the chat box for a link to that report, as well as an op-ed Dr. Frieden published in CNN.com yesterday. So Dr. Frieden, can you share with us a little about that report and why it matters right now?
The bottom line, Chris, is that epidemics don't have to happen if we invest in preparedness. Over 2 years ago, we began planning this report because it occurred to us that every day around the world, public health and healthcare workers are succeeding in stopping outbreaks from expanding to become epidemics. And yet, that's the story, like the famous dog that didn't bark in the night in the Sherlock Holmes story. That's the story that almost never gets written about. These are success stories. And it's certainly important that we study our failures, and there are plenty of failures in public health to study. But it's also important that we learn from successes. What works? What's effective? Epidemics That Didn't Happen looks at 4 case studies from around the world pre-COVID and 4 case studies from the COVID pandemic, and shows that with good communication, good organization, effective action, it's possible to prevent epidemics. We know that there is an ongoing risk of epidemics and pandemics. We're all connected. There is an increase in new pathogens. There is more animal-human interface. There's more drug resistance. And COVID shows the cost of failure, not only to health, but also to education, economies, social stability. And this is failure that's occurred in all types of countries, in all regions of the world, at all levels of income. But success is possible by having the critical components in place and good governments. We just don't usually hear about it. So Epidemics That Didn't Happen shows us a way forward to a world where epidemics don't have to happen, where a safer, healthier world is possible. And the time to start this work is right now. There's never been as teachable a moment as the present, with more than $10 trillion of costs, with more than 3 million deaths, and sadly, the likelihood that COVID will kill more people in 2021 than it killed in 2020. We have not just an opportunity, but a responsibility to make the world a safer place. And our report, Epidemics That Didn't Happen, shines a light on the successful work of health workers and public health workers around the world. And really, it's a message of hope, of optimism, that epidemics don't have to happen if we take advantage of this opportunity to make the world a safer and more secure place.
Great. All right. Well, thank you for that. So in March, you published a paper in BMJ Global Health titled "The World Must Prepare Now for the Next Pandemic." What are the major reforms and investments the U.S. and partners should be making now to prepare?
I use the simple acronym TOP, T-O-P, Technical, Operational, Political. There's a lot of focus on more money for preparedness, and that's absolutely needed, but it will be necessary, but not sufficient. We need much stronger technical skills, and there's not going to be one way to do that. One promising approach is through a consortium coordinated by the World Health Organization that would be parallel to something that's called the Global Outbreak Alert and Response Network, or GORN. It would be a global preparedness network. That's one example. A much stronger WHO, which has to be at the heart of our global efforts, is also necessary. Regional centers for disease control, such as the Africa Centers for Disease Control, which was very effective and remains very effective during the COVID pandemic. There are discussions to do this in other regions. That's important. But it's not only at the global level, but at the national level. We need more investment in public health. We need stronger human resources. We need a continuous improvement of technical skills. So that's the T of the top strategy. The operational means we need better management. Dr. Bill Foege, who really led the global eradication of smallpox, was asked after smallpox, what next? And he replied, the eradication of bad management. Well, we're not there yet, but it's really important that we have operational capacities to hire staff, to do contracts and procurement, to implement programs. Every aspect of public health requires good management. Some public health programs are more reliant on good management, and some have such strong technical tools that that's not as necessary. But certainly, if you take HIV, tuberculosis, and malaria, management is essential, whether that's managing bed net distribution programs or ensuring cohort analysis, so you're tracking the outcomes of patients. So it's not only technical skills, but also management or operational skills. And then, of course, the P, politics. And actually, then Vice President Biden used to say, show me your budget and I'll show you your values. And it's really accurate. For all of the lip service about preparedness or prevention or health protection or primary care or public health, show me the budget. And that then we'll understand what you really do value. But it's not just about money. It's also about spending political capital, whether that's political capital to close bars, or political capital to report cholera, or political capital to limit travel. Public health decisions are good for most people. They often will not be good for special interests, whether that's the tobacco or alcohol industry or some other entity. And so politics means not just putting your money where your mouth is, but also being willing to spend political capital on things that will save lives. And just to give you one example, and I would say maybe the most important example of this, and it's not in the infectious disease space, but it's tobacco taxes. Now, taxes on tobacco are the single most effective way to reduce tobacco use. Reducing tobacco use is the single most important public health problem in the world, more important than anything else that we work on. So you've got the most important intervention for the most important problem. And if you raise tobacco taxes, revenues will increase. So you're actually going to get more money by doing this. So why doesn't every country in the world implement effective tobacco taxation? Politics, plain and simple. That they are at some level valuing the profits of the tobacco industry more than the lives of their constituents. And that just is a microcosm of the importance of ensuring that public health decisions made by politicians are made to the greatest extent possible with the simple metric of, will it save lives? And Chris, just to ramble on here for a moment, I'll just tell you a story. I had the honor of being Mike Bloomberg's health commissioner. Mike Bloomberg, of course, has the Bloomberg Hopkins School of Public Health named after him. And our first big initiative was to increase the tax on cigarettes by $1.42 a pack, and that got through. And our next big initiative was to make all workplaces in New York City smoke-free. That was pretty far out there at the time. Only California, a couple of cities had done that around the US. It was seen as overreach. It was highly controversial until it was passed, after which it was highly popular. But when I pitched this to Mayor Bloomberg, he said, Are you certain this will save lives? And I said, absolutely. And he said, then we'll do it. That kind of political leadership is needed at local, city, state, national, and global levels. In this outbreak, we had a wonderful statement from the president of Ghana when he was implementing closures because of COVID. He said, we know how to bring the economy back to life. What we don't know is how to bring human beings back to life.
Yeah, right. Okay, thank you. So what is the role of current global health programs in greater pandemic preparedness and health security? What's the role of current global health programs, and what does a strengthened global pandemic preparedness architecture look like to you?
Well, first, WHO has to remain the anchor of our global health programs. And that means a stronger WHO that does certain things really well: set guidelines, do surveillance, and support countries. Second, I think there's a crucial role for the Global Fund. I think a preparedness window at the Global Fund would be very important. The Global Fund is effective at working in country. It's effective at moving resources accountably. This has to be done carefully because the stakeholders are different at the national level for preparedness than they are for HIV, TB, and malaria. But the Global Fund is, in my view, the most likely major contributor to rapidly improving preparedness globally. Development banks have an important role to play, and to the extent that they can provide grant rather than loan funds, they're going to be more effective. Gavi, the Vaccine Alliance, will be very important for procurement. The United Nations can play a crucial role. There's a Global Preparedness Monitoring Board, or GPMB. It currently is, frankly, too closely allied with the World Health Organization. It's not independent enough. If it were allied with the UN Security Council or the UN Secretary General and given more independence, it could have a powerful role. It's often compared with the Independent Monitoring Board for Polio Eradication. I'm on that board, and Sir Liam Donaldson has done a terrific job for more than a decade, making the reports of that board science-based, hard-hitting, practical. And that's the kind of independent accountability framework that we need from the United Nations. I think for that, we need to agree on a target. And as the HIV world agreed on 90-90-90 as a galvanizing target, we at Resolve have proposed 717, that every community, every country in the world should be able to identify outbreaks within 7 days of emergence, report them, investigate them, and begin response within 1 day, and implement effective response within 7 days. Because ultimately, we need to strengthen national and subnational capacities. All of the global health architecture in the world won't be useful unless we're focusing on what's happening on the ground. Are there laboratory networks, trained disease detectives, rapid response teams, effective communication, laws and regulations in place, plans and financing? But ultimately, those are capacities. The 717 metric would measure what's actually done, not what might be done. Because what we learned in COVID was that there were countries that had very well prepared public health systems that did very poorly in their response because of the lack of good governance. Using reality as our drill, making sure that whether it's an outbreak of measles or an increase in malaria, we are using the public health systems and assessing them by rigorous standards of timeliness and effectiveness is a way of tying our commitment to improve preparedness with the reality on the ground.
Great, thank you. So a little more on that. In your BMJ piece that we were just talking about, you write that, quote, a lesson from preparedness work over the past 20 years has been that the most effective emergency response systems build on robust, scalable systems that respond to everyday events, end quote. Can you give us an example of what that means? I mean, what are the implications of that observation for policy?
I'll give an example from the United States. During my time as CDC director, when we had the H1N1 influenza pandemic, we used the Vaccines for Children infrastructure to distribute vaccine. the monovalent vaccine for H1N1 that was available at that time. And that worked really well. VFC, as it's called, or vaccines for children, had 40,000 pediatricians enrolled, doubling that number, opening it up to all doctors and medical practice and hospitals, and using the shipment system, the ordering system, worked well. There were more than 120,000 deliveries of vaccine, refrigerated, without a glitch. In contrast, when it came to sending Tamiflu out, there was no system to get that used. So it was sent to state health departments where it really didn't work very well. And not that it didn't work, but it wasn't distributed to primary care and hospital groups. So children didn't get the Tamiflu they needed, which would have been quite helpful and may well have prevented some deaths from that pandemic. Now, the implications here are that we need to look at all of the programs that we run and think of how they can be multi-purposed for epidemic prevention. And we need to look at the ongoing outbreaks that we're dealing with and learn from them and improve our ability to find them, stop them, and prevent them. And that may mean anything from making sure that specimen transport systems for HIV and tuberculosis can be used for unknown pathogens, or that vaccination programs can engage the same community groups being enlisted in the care of patients with HIV, or that bed net distribution programs, both in the community and in healthcare settings, can be used for oral rehydration salts in the case of a cholera or other outbreak. The point here is that we need to do much better making sure that the investments we're making will be useful not only for the acute problem we're dealing with, but to strengthen the public health and primary healthcare system more broadly.
Great. Okay, thank you. And yeah, you did see in the response to COVID globally, those investments in HIV, TB, malaria responses really were useful in so many ways, including in so many countries, the community mobilization around responding to those epidemics was really useful in responding to COVID. And good segue into this question. Today, many policymakers are focused on health security, and that's what we're talking about today. But, if we'd had this talk 15 months ago, before we knew about COVID-19, we might be talking about the concept of universal health coverage and better access to primary health care, which is something that was and is animating policymakers and advocates around the world. So we've talked about strong systems for health as being crucial for pandemic preparedness. What is the health security? How is the health security agenda different from UHC? And where do they meet up? And what are the implications for policy and financing?
Well, I think UHC sometimes can ignore public health, and we certainly need to strengthen public health systems around the world. The amount of money needed is not clearly known. Our experience is between $1 and $5 per capita annually in lower income countries, well implemented, is likely to make a step function improvement in public health capacities around the world. So we need more resources, and again, technical, operational, and political. But the area I think where health security and UHC meet is in primary care. Primary care must be primary. And I think in all of our programs, we give lip service to it, but there's just not enough progress. Primary care systems are crucial to the care of HIV, to preventing death from malaria, to the treatment of tuberculosis, and in our own work, to the treatment of hypertension. And yet they're really quite weak around the world. Primary care is the most neglected and yet most important part of the healthcare system. In some of the work on UHC, I cringe when I see an additional focus on specialized hospital care in systems that are already imbalanced in their emphasis on primary versus hospital care. And actually, Chris, just earlier this morning, I just finished a roundtable with the Council on Foreign Relations with leaders from Costa Rica and Thailand, two countries that have made enormous progress in primary care. to try to learn what are the lessons and how can that be applied elsewhere. And I'll just share with you the 6 things I learned earlier today from those 2 countries. First, there is a political consensus in both places that primary care is important, and that transcends political parties, religious groups, types of government. Second, care is capitated, so there's an incentive to give primary care. Third, payroll taxes are an important part of financing the system. Fourth, community health workers are integral to the care, as is team-based care. Fifth, public health and healthcare are integrated, so you get a real collaboration between public health and primary care. And sixth, primary care services are recognized by communities as being effective, important, and as gateways to more specialized systems of care. So I think we need to recognize that since Alma Ata, near 45 years ago, there's been discussion of primary care, but more lip service than progress. And it's not going to be quick. Both countries described a decades-long effort to improve primary care. And we don't have decades, but we do have to really be blunt about the need to improve primary care, because if we don't do that, we won't have people in place to detect problems when they first occur, or people to provide the vaccinations. So both public health and primary care have a unique opportunity to be greatly strengthened in the wake of the terrible COVID-19 pandemic.
All right, thank you. So you were as I said, you were at the center of global efforts to tackle the Ebola epidemic in 2014 and later. What was that experience like, and what did you learn from it in terms of being prepared for future pandemics?
Well, first, community is enormously important. Every community has strengths and weaknesses, and the key to effective response is to identify and enlist those strengths and to recognize and limit the weaknesses. An organized response is crucially important. My first trip to West Africa during the Ebola epidemic had a simple goal, which was to make sure there was an incident management system with an empowered incident manager in each of the 3 countries, that person reporting to the head of state. And that's really important. An organized response is the essence of effective response. Second, that responses have to be science-based, understanding that we're continuously learning. And so we do need to adjust and adapt our strategy as we do so. Third, that effective communication is enormously important. And that means 2-way communication, understanding what the perceptions are, what messages will be effective, what messengers will be effective, and the importance of global coordination and collaboration, because ultimately there was collaboration from the community level in West Africa to global institutions, recognizing that we had only one enemy, a virus. And that's the case now with COVID also. We need to try to avoid partisan, global, political tensions, recognizing that there's only one enemy here. It's a microbe, in this case, a virus. And the more we're divided, the more the microbe will conquer. And the more we learn, we adapt, because microbes learn and adapt. That's what evolution is. The better off we're going to be, the safer we're going to be, the more secure we're going to be.
All right. Okay. Thank you. Well, we've got questions coming in, and again, you can put questions in the Q&A box, but let's start off with some of those and get to as many as we can. First one, how much does implementing country ownership in partnerships for global health security matter? Does that point to any current assets to build on?
Country ownership is key. Funds for global health security are never going to be the bulk of what's needed. There needs to be a national consensus and focus on improving preparedness. We need to shine a light on areas where countries aren't prepared. And ultimately, if countries don't buy it, we're not going to have the kind of progress we need. Now, the fact is that preparedness is sometimes seen as something that's of greater interest to rich countries than poor countries. The argument here would go something like, you only care about us if the diseases that we get might spread to you. And sometimes we do find that to get the US Congress to fund preparedness, we use arguments along those lines, that we're all connected, that a health threat anywhere is a risk everywhere. But it's also the case that outbreaks are very destabilizing, that the ability of businesses to operate, of schools to educate, of families to raise their children in a healthy way depend on avoiding outbreaks and epidemics. Chris, many years ago, I traveled to Scotland along with the Director General of a lower income country health service. And when he got there, he said, "Where's the bottled water in my room?" And I said, "Well, you don't need bottled water, actually. You can drink it out of the tap." And he couldn't believe it. It was outside of his just worldview that you could turn on a tap and drink water that won't make you sick. And that ultimately, that's a kind of change that we need to make. We need to have the expectation in the world that your food, your water, your air, your contacts with others aren't going to make you sick.
Okay, right. Next question. In addition to national level approaches, what is needed is adequate, trained, and experienced public health and primary care workforce. Implementation of TB elimination efforts will accomplish these needs. Why not implement elimination of the current TB pandemic?
Well, as you may know, I worked for many years on tuberculosis. I think we need to be realistic about what can be achieved. Right now, we're in a terrible situation. TB control has been set back for years. We can debate how many years, but for years. Many patients weren't diagnosed. Many patients didn't continue treatment. There's been a huge spread of TB. Tuberculosis control requires persistence. The TB bacillus is persistent. It persists in our bodies for a lifetime. It persists despite treatment for at least 4 or 6 months. And if we're going to overmatch it, we need to be persistent. So by all means, we should be scaling up tuberculosis diagnostic, treatment, and control services. But we also have to recognize this is a long-term program. And I'm glad that organizations have called for global elimination, but I'm a little frustrated when entities call for something for which there is no current way to achieve, And the fact is, we don't have current ways to rapidly control tuberculosis. We can do a lot better with detecting it through health systems, with treating it completely and sensitively, with monitoring effectively, and we hope for a vaccine. Maybe mRNA technology will give us a vaccine for tuberculosis. So we need to be studying ways to do better, but implementing what we need to do now much better than we are on tuberculosis.
Right. The next question from the audience. Could you speak more about community health workers? What does the world need to do to empower, equip, and train them as other countries' heroes and for the first line of surveillance in the first 7 of your 717? Who's currently best at international efforts on empowering community health workers?
This is a great question, a great issue. We see certain characteristics of effective community health worker engagement. One is they have to be really well integrated with the healthcare system. If they're just, as a staffer of mine used to say, walking around talking to people, that's not going to be nearly as effective as if they are an integral part of the health system. And again, from this morning's session, in Thailand, there are something like 1 million community health volunteers in a country of 60 million people. And they're in every health center. And they're essential for everything from positioning patients, taking their blood pressure, delivering medications, being supportive, translating. Community health workers are part of the health system, not a standalone entity. But they also need to be paid. They need to be trained. They need to be respected. And I guess one question is, how does that happen? And one way that happens is to have a financing system that encourages that. And that may be a capitation system. I think this is an area where we need more progress. Community health workers, there are lots of failed models of community health workers who are hired, not supervised, not trained, not supported, not adequately paid or integrated with the system. There are countries in which there are multiple different types of community health workers that have been tried out and not worked so well, and others that work really well because they're in the community, they're trusted by the community, and they have services that the community values. So I think thinking about the best practices here is really important, and making sure that they're well integrated with the healthcare system and paid for the work that they do.
You know, we got another question on this, so let me ask that as a follow-up. We all know community response is a worthy investment, but why are most funds still channeled to government, leaving community actors with very little, and little goes to, I guess a lot goes to large NGOs and not community-based organizations?
Well, I think we have to think of what's the problem and what are we trying to address. And for a lot of it, funding to governments is really important, because ultimately it's the government that has to run the surveillance system, set the guidelines, set the framework. That doesn't mean government needs to provide all services, and contracting for services or funding with grants or otherwise, community organizations can be crucially important to disease outbreaks. Look at the local Red Crosses in Ebola that were essential to stop the outbreaks, or global NGOs that moved in, like Alima and others, MSF, that did terrific work. So community organizations are extremely important, and we have to figure out the best link. I'll give you this. In all of the organizations and all of the initiatives that I've had the privilege of starting, I've taken essentially a three-part approach. First, strengthen the public sector. You need a strong public sector. Second, strengthen civil society. And civil society might support, push, or provide essential services that are needed by the government and by society. And third, establish effective tracking and monitoring systems so that you can keep everybody honest, so that if programs are improving, you can protect them. If they're not being effective, you can improve them, whether they're government programs or community organization implemented programs. Let's look objectively at what's happening and continuously improve it.
Great. Right. Next question from the audience, and we got about 3 minutes left. What role, if any, can the private sector play in the health security agenda in a country?
There are lots of different components of the private sector. So there's no one answer to that. And there are lots of different setups in different countries. There are places where the private sector provides important parts of healthcare. They need to be integrated with and aligned with the national policies. There are some programs for which we need resources or materials from the private sector, whether that's low-cost personal protective equipment or vaccines and biologicals or medications. But there's also another role that I've seen private sector play very effectively. If we as public health advocates go to the government, or if academic researchers go to the government, or doctors and nurses go to the government and say, pay more for public health or primary health care or this or that health problem, we're generally listened to politely. But if leaders of business and industry go to government and say, we must do this for our competitiveness, for our reputation, for our society, frankly, they're more effective than we are. So having private sector leaders advocate for primary health care, public health, and specific health programs like global health security, HIV, TB, malaria, has been and will continue to be a crucially important function and service that the private sector can play.
Great. Okay. Well, Dr. Frieden, we have reached the end of our time for today. I want to thank you very much for your time. This has been fascinating. And I want to thank the audience, everybody who's joined, but also for your questions, and really encourage folks to read some of the things that Dr. Frieden's been writing on health security. We talked about the BMJ global health piece. He also wrote on tracking all of this in foreign affairs recently. So a variety of things. And then the new report out yesterday, nscnn.com piece. So thank you very much, Dr. Frieden.
Thanks, Chris. It's always a pleasure speaking with you. And thanks to all of the people out there doing activism, work, service. It's really all of your work that makes a difference and brings us hope that we will have a safer, healthier, more secure world. Thanks.